In this video, I'll go through the topic of flexor tendon injury and repair, which is a very fair game topic for your hand viva in the FRCS Trauma and Orthopaedics. The scenario may well begin with a clinical vignette, and you can be presented with a story and a photograph potentially of a patient who's sustained a laceration to the volar aspect of their finger or hand, and the structures that are injured include, but are not limited to, your flexor digitorum profundus tendon, your flexor digitorum superficialis tendon, and your neurovascular structures. But the discussion will probably quite quickly come on to asking you, what are Verdun's flexor zones? What are the zones of injury? Now, I always used to panic in terms of quickly trying to remember the difference between the extensor zones and the flexor zones, because it's not exactly the same. But I'll show you three key parts of the anatomy that, if you remember, it's very easy actually to remember all of your flexor zones. So here I've drawn a quick schematic of the hand, and you've got metacarpal P1, P2, P3. And in terms of your flexor tendons, you can watch a separate video on this channel about the anatomy of your flexor tendons. But you've, essentially got FDS, flexor digitorum superficialis, which is superficial to flexor digitorum profundus, which comes and inserts into the distal phalanx. But the anatomy of flexor digitorum superficialis is such that there's a sort of Y-shaped split at the level of the proximal phalanx, whereby the two parts of that split of FDS then come and insert either side into the middle phalanx. But that's called campus chiasm, basically, which allows FDP to come from deep through that split of FDS and insert into the distal phalanx. But the insertion of FDS in the middle phalanx is your first bit of anatomy to remember, because that is where the first landmark is. So the insertion of FDS, anything that's distal to that, is flexor zone 1. A flexor zone 1 injury is essentially the rugger jersey finger, whereby if you've lost your flexor tendon here, then you won't be able to flex at the DIPJ. So if you ask your patient to make a fist, usually you can do that, but in rugger jersey finger or jersey finger, there'll be no flexion at the DIPJ. Your next bit of anatomy to remember, again, is covered in a separate video that I have made on the flexor pulley system. And if you watch that video, you'll see that at the level of the MCPJ, you've got the A1 pulley. Yeah, the first annular pulley. And that A1 pulley is your next bit of anatomy to remember, because anything between the insertion of FDS and your A1 pulley is flexor zone 2. The key thing to say about flexor zone 2 is that you've got both the FDS and FDP tendons in the same sheath. And again, if you watch that video, you'll see there's vinculi. And if the vinculi are cut, then you can get retraction of the tendons down the sheath. Within the sheath, there's an increased risk of the formation of adhesions, and so it's very important after any direct repair that you get your patient going with early range of motion exercises. So, FDS insertion, A1 pulley. The next bit of anatomy in the hand to remember is the carpal tunnel. So the distal carpal ligament is your anatomical landmark, in that anything between the A1 pulley and your distal carpal ligament is flexor zone 3. In zone 3, statistically, there's an increased risk of neurovascular injury. So your avocado hands and all that sort of thing, be wary about neurovascular injury. Zone 4 is the carpal tunnel. Contained within the carpal tunnel, of course, are your tendons as well as the median nerve, but that is flexor zone 4. And flexor zone 5 is anything from carpal tunnel up the forearm. And then you have it, zone 1, 2, 3, 4, 5, done. All right, and you're just remembering 3 bits of anatomy: the insertion of FTS, the A1 pulley, and the carpal tunnel. And then if you extrapolate that across all the fingers, you'll probably get, the diagrams that you get of your zones that look sort of like that. when your patient presents to you clinically and you're suspicious of a flexor tendon injury, there's 3 key things to quickly check. There's your resting posture. If you relax your own hand in front of you right now, no tension at all, you'll find that the natural resting posture is, with a bit of flexion in the fingers, and that's nothing other than just the natural tension length relationship of the muscle bellies and your tendons, both on the extensor and the flexor sides. And this you can extrapolate to something called the tenodesis effect, which is a good clinical exam, but also, let's say your patient is anaesthetized and you're exploring a laceration, for example. It's an excellent test whereby, again, relax your hand completely. You'll find that you've got a certain resting position. If you then passively flex your wrist, you can try it on yourself, your fingers will want to extend, and that's just because of the natural tension length relation of your extensor tendons. And again, if you passively extend your wrist, you'll find that your fingers flex more. And again, for the same reason. But if you've cut a flexor tendon, then you will lose that, and that is loss of the tenodesis effect, which will tell you that you've got a flexor tendon injury. If you're examining your awake patient, then of course loss of that active flexion strength is something that you will see the patient has. So that is your flexor tendon zones and the clinical assessment. Now, if we talk about tendon healing, there's 2 main pathways. Tendon healing we can divide into the intrinsic pathway and the extrinsic pathway. What this means is the tendon will heal from within itself or from the surrounding synovial fluid, cells and factors that come and have this external effect on them. The intrinsic pathway is what we go for if we've repaired a tendon and we're going for an early range of motion protocol. With the intrinsic pathway, it's all tenocyte mediated, so it's tenocytes that proliferate and migrate from the epitenon, the endotenon, and deposit type 1 collagen to directly heal the structural integrity of the tendon. The advantage of this is that there's less in the way of adhesions, which means that that's much better for your movement and function. However, this is a much slower process, so that is something to bear in mind. The extrinsic pathway is all from the surrounding synovial fluid and the external cells and factors that are within that. And what that does is it produces this sort of inflammatory process. There's actually 3 stages. So the first is the inflammatory phase, which is generally sort of day 0 to 5, and there's a lot of cellular proliferation. Particularly then you get proliferation of fibroblasts, and you're into the fibroblastic phase, where there's fibroblast proliferation and deposition of quite a lot of disorganized collagen, basically. But because it's disorganized collagen, that leads us on to the 3rd phase, where it remodels, and you've got the remodeling phase, and you get more linear organization of that collagen, and that's when it can tolerate an active range of motion. The disadvantage with this, however, although it's faster, is that there's increased formation of adhesions, which is bad for your function and movement. So let's talk about the $1 million diagram, which your examiner will very happily ask you as they pass you that A4 sheet of paper, and they'll say, draw how you would repair a flexor tendon. So here's our cut flexor tendon, let's say. While you're on YouTube, there is a fantastic video on this already, specifically about the Adelaide technique by Dan Armstrong from the Pulvertuft Centre. I'd recommend you look that up while you're here on YouTube. But for the purposes of my videos for the FRCS, the way I think about this, to very quickly draw something, is just think about the Roman numeral 10, and that's all you need to draw in the middle. All of us during our training will learn about sort of the modified Kessler technique, which is a two-strand core suture repair. However, I think what your examiners will want to hear is that you favour a 4-strand core suture repair. So I'll write that here, 4-strand. God, I'm I'm always smudging everything in these videos, aren't I? But anyway, so your 4-strand technique, this is essentially a modified sort of cruciate suture. Your knot will be in here. And in Dan Armstrong's video, he draws these nice dots that show you where the suture is entering and exiting. But if you wanted to do that for your examiner, you can. And the key thing always is draw big diagrams, draw and talk at the same time, and be quick. So you say, I'll come in with my suture here into the tendon, out and back in again, out, and I'll cross, come out, back in again, and then come out, and so on. And then you can just draw for them that you're doing this modified cruciate technique, and your knot's going to be tied there. Same concept, but I don't know, personal preference. I find this a little bit neater to draw, basically. It doesn't matter what you draw, as long as it's something that is a four-strand core technique, and your core suture is 3-0. So as I said, it doesn't matter what you draw, it's about the principles. And the principles are you'll have a 4-strand core suture technique plus your epitendinous repair, circumferentially, which is probably a 5-0. And what that does is it increases your strength by about 20%. So let's say you've repaired your tendon with your core sutures and you've tightened the knots. So you've got this, but to prevent gapping and increase your strength, you can come in and do essentially, there's various ways of doing it, but you can tell your examiner, I would just do a continuous running epitendinous suture all the way around the tendon to increase the strength. Other principles to talk about. You want easy placement of these locked sutures, and your bites, by the way, importantly, are 1 centimetre for the best placement. You want nice secure knots. I'm going to put 3 throws down on this and bury these knots. I want minimal gapping, and if anything, I can accept 10% shortening because I know that everything's going to stretch out with the rehab process. You want to talk about atraumatic handling of your tendons and respecting the vascularity, and certainly in the fingers about preserving your A2 pulley and your A4 pulley as well. All of those principles are key when you're drawing your diagram of your tendon repair, and then you're on to talking about the rehab. And you don't have to go into too much detail, I think, as long as you say you're going to adapt an early passive mobilization or a protected early range of motion regime, and you can quote such as Belfast or Manchester. Orthobullets still has things like Durant and Kleinert written all over the place, but those are more out of vogue now, especially with your hand surgeon who will be across the table in the FRCS. Belfast, your reference for that can be Trumbull et al. 2010, but essentially it's an early passive mobilization regime. You have the patient's hand in a dorsal blocking splint, so it allows controlled passive flexion of the fingers. And for the first 4 weeks, it's all about controlled passive flexion exercises with the hand in the splint. And then from 4 to 6 weeks, you can move on to the gradual introduction of active flexion. And then from 6 to 8 weeks, you can try full active range of motion and strengthening exercises. The risk of rupture is mitigated against active mobilization methods, and your risk of adhesions is also minimized as well. Right, I think that's all I'll say for this particular video. Thank you very much for watching, and I hope that was useful.